Me okay? And Sarah, thank you so much. And I'll just stand up here and talk to all of you. And it's really my pleasure to be here and talk about lung cancer and lung cancer update. But I especially wanted to thank Sarah and the whole team for putting this together. And really, it's nice to be in person post-COVID or during COVID at the same time. So at least these are my disclosures. This is the outline for introduction as well as some of the abstracts that I'll be discussing. And as Dr. Kazmi said, you know, lung cancer is a huge problem for all of us. It's epidemic, it's endemic, and it is not only a men's problem, it's a women's problem. It's all races problem. It's all LGBTQIA problem. And we really have to be cognizant that it's not necessarily just the smokers, it's the non-smokers issue as well. So we know, I actually started my career about 32 years ago, and clearly 50 years ago, historically, lung cancer was one disease, then it got subdivided microscopically, then we're using precision medicine to be able to subdivide lung cancer further. So lung cancer, in my mind, is no longer lung cancer. It's a cancer that arises in the lung that has many different characteristics, and we need to be able to define those characteristics. And as Dr. Razmi showed, that there are so many therapeutics available that we have to be cognizant that this is a very important and moving field itself. So there are mutational heterogeneities of lung cancer. Like I said, lung cancer can be different variations, and as you can appreciate, you can have gender, race, smoking, age, ethnicity, but you can also have mutations, and many other mutations are being discovered, and many therapeutics are being discovered as well. There's tumor heterogeneity that drives the therapeutic heterogeneity in response. And each row is represented different patients, and you can see the different therapies for the same diagnosis of non-small cell lung cancer, and especially adenocarcinoma, that you can appreciate every patient is different. So it's not just about precision medicine, it's about personalized medicine in lung cancer. We can also, as you just heard, track tumor evolution through ctDNA. This is some of the data set that has been published through our group over the course of the past 7 years. But we also know that it impacts on the survivability for patients. So it is crucial to do next generation sequencing, as you just heard from Dr. Kazmi. It's very important to be able to characterize each and every one of your patients. So taking all of that into account, there are several ASCO abstracts I wanted to highlight. First one is from the FDA, looking at PD-L1 scores greater than or equal to 50%. And this is a retrospective analysis, trying to look at chemotherapy, immunotherapy in combination versus immunotherapy alone, and looking at that specific population that has a higher PD-L1 that is greater than or equal to 50%. And this is non-EGFR, non-ALK population. And what they were able to do is look at various clinical trials, such as the Keynote clinical trials, the Empower, the Checkmate, and then put it all together where they identified that indeed chemotherapy, immunotherapy versus immunotherapy alone, the median survival was, the median was actually overall survival of 25 versus 20.9 months. But what's important is that you don't see that much of a difference in terms of chemotherapy, immunotherapy versus immunotherapy alone, except in a population that's greater than or equal to 75 years of age. So that's where it made the biggest difference to have immunotherapy by itself. So the summary for this is that pooled analysis does not suggest a difference in overall survival. The observed differences in PFS and overall response rate needs to be interpreted further, and the older age group may benefit with immunotherapy alone, and more studies need to be done in a prospective fashion. The second study that relates to immunotherapy, we really are facing a challenge. You develop resistance through targeted therapy, but you can also develop resistance de novo or out back in terms of immunotherapeutics. So this study from SWOG looked at how you can take previous therapy with PD-L1 agents and then standardize it either once you fail it against chemotherapy plus ramucirumab, as you can see in Arm B, or in Arm A with standard of care with chemotherapy alone. The overall survival for median overall survival for ramucirumab and pembrolizumab was 14.5 months. And that's actually very important because the standard of care was 11.6 months, but the hazard ratio was quite significant, as you can appreciate here. And the standard of therapy that many patients received was taxotere or docetaxel with ramucirumab. And this is the progression-free survival, and this is the analysis of the various histologies and the TMB and biomarkers. Really, it was quite effective in all of the population that was studied. And this will become standard of care as we look forward to failure of pembrolizumab or failure of immune checkpoint inhibition, and then combining that with ramucirumab itself. And this is the best objective response, as you can appreciate, with the P and the R versus standard of care. And the duration of response was 12.9 months versus 5.6 months. So this is a very seminal study where ramucirumab and pembrolizumab in patients with advanced lung cancer were previously treated and then retreated with immunotherapy plus an anti-angiogenic agent. And you did see that compared to docetaxel and ramucirumab, this was much more effective. And of course, more studies are needed. Then coming back to the FDA, they're doing a lot of pooled analysis, retrospective analysis. They looked at KRAS mutation. You just heard about KRAS G12C, but what about the non-KRAS G12C mutations that can occur? At the same time, is immunotherapy effective in the wild-type KRAS versus the mutant KRAS? So this was looking at immune checkpoint inhibition with chemotherapy versus immune checkpoint inhibition versus chemo alone, and looking at the KRAS mutation versus KRAS wild-type. And you can appreciate highlighted in red that the immune checkpoint inhibition with chemotherapy was similar in the G12C versus the mutant versus the wild type. And the median overall survival, was, as you can see from the mutant versus wild type, was 22.4 versus 18.7 months. And what's really important to conclude here is that patients with KRAS mutations benefited from the ICI immune checkpoint inhibition with chemotherapy similarly to those with KRAS wild-type non-small cell. And all patients appear to benefit from adding chemotherapy to ICI regardless of PD-L1 expression and KRAS mutation status. The optimal control arm for studies of the first-line therapy may be immune checkpoint inhibition with chemotherapy. And of course, the G12C has to be subanalyzed, and especially if sotorasib is already approved, and adagrasib may get approved over time, and we need to be able to go forward. So talking about adagrasib, and this is moving away from checkpoint inhibition therapy, but looking at targeted therapy. So targeted therapy, you can have KRAS G12C mutations that occur very commonly in non-small cell lung cancer adenocarcinomas. They don't occur as much in pancreatic cancer or colorectal cancer. But there are two drugs that are being studied, and one is sotorasib, which is already approved by the FDA, and the other one is adagrasib. And this looked at really adagrasib at 600 milligram twice a day, and the objective response was the overall, primary endpoint was the overall response rate itself. You can see this waterfall plot as well as the median PFS and median OS. And the median PFS for this single agent was 6.5 months, and the overall survival was 12.6 months. That's important, but we also have to realize it's not good enough. And the reason why I say that is, of course, targeted agents such as in EGFR space or ALK fusion space or ROS1 fusion space has so much better PFS as well as overall survival. So we do need to think about adagrasib, and there have been responses in the brain as well. So CNS is a sanctuary site for KRAS G12C. So it will be important as we look at adagrasib in the brain. And the overall response was 43%. The 1-year overall survival was 51%. And clearly ongoing studies are happening as we speak and being presented at the World Lung as well this week and over the weekend, or over last week as well. So going on to another targeted therapeutic biomarker such as EGFR. So EGFR, you can have mutations in L858R or exon 19 deletion, but you can have mutations in exon 20 or alterations in exon 20 where amivantamab has been approved. But in this study, they looked at amivantamab with lazertinib in the context of EGFR mutations, exon 19 deletion as well as exon 21 abnormality, where you can see that in cohort A that was presented, And this is looking at the overall response rate, primary, and the other secondary endpoints are listed here. And this was the safety and efficacy results of amivantamab and lazertinib. And you can actually see that this is a quite effective regimen. And as you can see in the black outline, such as the prior therapy group, the osimertinib and then platinum-based chemotherapy or heavily pretreated and out of sequence, the overall response rate was about 25 to 30%. And that's still important ipso facto failure from osimertinib. And it does have CNS activity. And again, EGFR mutant patients, you can have CNS disease. We've done a lot of artificial intelligence to be able to show CNS disease in KRAS mutation versus EGFR mutation versus ALK fusions are looking different in the brain metastases as well as patterns of metastasis. But we know in this EGFR space that amivantamab in combination with lazertinib was effective in CNS metastases. So at least the treatment benefit I've just gone over with you, and its activity in post-osimertinib space is very important for us to continue to look at. The safety profile, it was very well tolerated, and the key takeaway is really more studies are needed, such as the CHRYSALIS-2 and the MARIPOSA-1, MARIPOSA-2 studies that are ongoing. And at the same time, I was part of this study. It is effective in MET exon 14 skipping, which actually got discovered in my lab in 2003. And at the same time, what we have to be able to do is go beyond the metastatic setting and go to the earlier settings, such as stage 1, 2, and 3, as Dr. Kazmi talked about. And one of the big questions for us is, can you give neoadjuvant therapy in early stage disease to be able to come up with cures for our patient? We had done a lot of studies. I've been in practice for over 32 years now as a medical oncologist, and we've done a lot of studies over the course of 30 years. And we know that earlier stage disease was tough code to break compared to later stage disease in terms of molecular oncology. But at the same time, neoadjuvant therapy is here to stay. And this was comparing sintilimab and immune checkpoint inhibitor in looking at 2 cycles versus 3 cycles in a neoadjuvant study, combining it with chemotherapy. This is the schema that you can see. It was sintilimab plus chemotherapy versus, for 2 cycles versus 3 cycles. And patients got surgery ipso facto the 2 to 3 cycles. And then at the same time, they looked at primary endpoint. And there was, in 3 cycles, treatment presented a 14.5% increase in the MPR rate in comparison to 2 cycles. And we also know in the secondary endpoints, 3-cycle treatment presented a 4.9% increase in the pathologic CR rate in comparison to 2 cycles themselves. The tumor response for histology was quite significant as well. That patients with squamous histology achieved a significantly higher MPR, major pathologic response, compared with non-squamous subtypes in both groups. And similar trends were observed in the PCR rate and overall response rate themselves. So the conclusion was quite significant here. That is that it was a randomized study of 2 versus 3 therapies, 3 cycles of therapy, and that immunochemotherapy was effective in the neoadjuvant setting. The MPR rate was 26.9 versus 41.4%, and it was important that it was more higher in the squamous cell carcinomas as compared to the non-squamous subtype, and it would be important to study this further, and you can really see that in 2 cycles, 44% versus 0% versus 3 cycles was 60% versus 21.4%. So the PD-L1 expression had a modest predictive value for pathologic response, and the neoadjuvant regimen with an extra cycle was very well tolerated. So if we can get neoadjuvant therapy for our patients, it is the way to go for early stage disease. And then finally, another regimen for early stage disease in terms of neoadjuvant therapy was presented, and this was nivolumab plus chemotherapy versus chemotherapy for resectable stage 3A and B non-small cell lung cancer. This was the NATAM-2 trial. And what they looked at was the experimental arm versus the control arm, as you can see in terms of the study design, and that was nivolumab plus paclitaxel and carboplatin versus chemotherapy alone, and then undergoing surgery and then following up for 5 years. And that's an important one. They also looked at blood samples and they looked at stool samples too, but they didn't really present that because I do think the microbiome is incredibly important as we go forward to be able to for us to make a difference in therapeutic response. So this was the PCR rate with neoadjuvant Nivo plus chemotherapy versus chemotherapy in the intent to treat population. And you can see that it was really 36.8% versus 6.9%. And then as you can see, the MPR rate, quite significant in the second graph to the right, where the MPR is on the ordinate and on the abscissa is the Nivo plus chemo versus chemo. And you can truly appreciate very significant 53% versus 14%. And then the overall response rate was quite significant as well. So here, there are potential predictive biomarkers. I don't think we've come up with the best biomarkers for immunotherapeutics. We do use PD-L1 testing, but it's also important, as Dr. Kazmi pointed out, what is this PD-L1 testing? What are the biomarkers? This is the 22C3, the 28A, the SP, 263, and we are all trying to struggle in terms of coming up with the best biomarkers for immunotherapeutics. But basically, the better the PD-L1, the higher the PD-L1, the better response rate was to the nivolumab. So in the conclusions here, the NATAM-2 confirms superiority of neoadjuvant nivolumab plus chemotherapy combination in patients with resectable stage 3 and A and B. And the addition of neoadjuvant nivolumab to chemotherapy significantly improved PCR. It maintained a tolerable safety profile with moderate increase in grade 3-4 toxicity. It did not impede the feasibility of surgery. And the PD-L1 had a predictive value that was important. So it is important for us that we are breaking through the ceiling for non-small cell lung cancer. We need to pay a lot of attention to small cell lung cancer. And we also need to be able to make it better in terms of quality of life, as we've discussed throughout this meeting, for our patients as well. So if there are any questions, I'm happy to answer them. Thank you for inviting me. And I did finish 17 seconds earlier.
Thank you, Dr. Salgia. Any questions from the
Jamie? Yeah.
audience?
Thank you so much. So I do struggle with the neoadjuvant patients. I know that there is the option of perhaps downstaging them, and we still don't know maybe the implications of a pathological complete response or a major response in these patients, because with the Empower 010 data and the idea of giving adjuvant IO for a year compared to just giving 3 cycles of an IO to a patient before resection, which doesn't continue on, how do you handle those 3A patients?
The best way to handle that is trying to think about a clinical trial. If they qualify for a clinical trial, I highly encourage the patients to go on it. It's a very much a gray area. You know, we discuss this at our tumor board every week with our surgical colleagues and radiation and med-onc colleagues themselves. There's no right answer. I think some of the sine qua non that I can actually say, do the next generation sequencing. If they have an EGFR mutation, they won't respond. So do they then, will they respond to, let's say, a targeted agent or a combination of chemotherapy with targeted? Another question to answer for the future. If they have an ALK fusion, will they respond to immunotherapy? No. If MET exon 14, they won't. So I think if you have these fusions or these molecular alterations that don't respond to immunotherapy, by definition, you already have an answer. So this is actually, as they say in mathematics, quod erat demonstrandum, the QED, proving by negative examples. So those patients who can qualify for chemoimmunotherapy certainly absolutely consider that. I think the immunotherapy to be given afterward needs to be discussed further. And at the same time, are we moving the needle by having such 40% PCR, pathologic response? I suspect so, but we have to follow the patients for over 5 years to be able to make a difference. But if we don't do it and stay stagnant, I don't think we've accomplished for our patients. So clearly a lot to discuss with our patients.
Thank you, Dr. Salgia. One question from the virtual audience. Can you disclose or do you know your institution's rate of complete molecular testing?
Yeah, so I can actually disclose that. So City of Hope is a very unique place, and as you know, when I first started 6 years ago, there were 7 sites that we called the clinical network. And just in Southern California, before we joined our forces with the Cancer Treatment Centers of America very recently, we have 37 sites in Southern California. When I first started, we had, as the chair, we had 35 faculty members in medical oncology. Now we have over 105 faculty members, and that's without counting the CTCA. And actually, every faculty member is part of the department, so it's not like an adjunct appointment per se. So we take pride, and actually we published a book last year, and people are welcome to download it as a PDF, where we really made ourselves the champion to be able to say we should have 100% concordance, 100% next generation sequencing. Because we're part of the same faculty, because we're part of the same department, and because we're part of the same institution, that becomes very easy. At the same time, we have our homegrown product called HopeSeq, so we can actually do that in-house. As you know, we're also partners with TGen, so TGen also belongs to City of Hope, and TGen, some of you know, is over in Scottsdale, and they do a lot of molecular testing, and that's where GemExtra or Cheyenne comes from. So we can actually not only do our, let's say 700 gene signature, but then we can also do whole exome sequencing as well as RNA-seq. And so we take the pride in the fact that we have 100% concordance. 6 years ago, I don't think I could have said that, but because we're one department, we make that decision together.
Wow, congratulations for City of Hope's commitment to that. Thank you, Dr. Salgia, for your presentation.
Thank you.